Hey everybody, welcome back. This is Nurse Eunice with Florida Training Academy, and you are absolutely correct. I have an updated 2025 CPR/BLS practice test just for you. It has 35 practice questions with real life scenarios designed to help you pass your CPR and AED and or your basic life support examination. So as we do in each of our videos, we're going to give you a few moments to receive your notifications and then get your pen and your paper and let's pass our exams together. So hi everybody. All right, so what's the purpose of this video? So whether you're taking the American Heart Association, an American Red Cross, or an Health and Safety Institute BLS or CPR class, this video is for you. How is that? Because all of the brands of CPR gather their data based off of international standards. So this is shared knowledge, just packaged a little differently based on the brand of course that you actually attend. And so the information I'm telling you is going to be good nationally because it's based off of international standards. So it doesn't matter that I'm in Florida, I'm still going to help you pass your examination. How? By reviewing real life-saving skills like CPR, AED use, how to perform CPR on a pregnant mother, rescue breathing, etc. I'm going to test your knowledge of team dynamics and emergency response and get you prepared for real-world scenarios. That's right. I just don't want you being able to pass a test. I need for you to pass the exam. And then if one of your patients has a cardiac emergency, I need you to know what to do. And I want you to feel comfortable and confident. And so here we don't use fear tactics. I want you to be able to learn CPR and be comfortable because if you're comfortable, you will speak up and you will let someone know if you need help. And that's the purpose of BLS. So CPR, think individual, layperson, single rescuer. When you think basic life support, think of you have a full team. And so if you get tired, if you need advice, if you need help, you have a supportive team there who's going to help you do whatever you can in order to save a patient's life. So great job, team. Whether you're a healthcare provider, a nursing student, or if you just need a quick refresher, this video is for you. And we also have a free library with CPR, BLS, ACLS, PALS, and CPR instructor resources, free videos on our YouTube channel. That is youtube.com/Florida Training. We also have our all disciplines American Heart Association classes right here in Florida. Our website is fltraining.com. And if you need free study guides, you know Nurse Eunice has you. Whether it's CPR, EKG, ACLS, you're going to go to nurseeunice.com. Again, I'm just not here to help you pass a test. I am here to make sure that you are a confident and a safe caregiver who knows how to respond if there is an emergency with your patient. Let's begin. As I read through these questions, if you don't already have paper and pen, pause the video, get paper and pen, and then come back. And then because I don't want this video being too long, I'm going to reveal the rationale, the answer, in a 3 to 5 seconds. So if you need more time than that to process, to really think about the question, pause the video. All right, so question 1. What is the recommended rate for chest compressions for adults during CPR? Would it be 60 to 80 compressions per minute, 80 to 100 compressions per minute, 100 to 120 compressions per minute, or 120 up to 140 compressions per minute? I know that was a mouthful. All right, revealing the answer in 3, 2, and you are correct if you chose C. So the American Heart Association recommends a compression rate of 100 up to 120 compressions per minute for effective perfusion. Question 2, what is the correct compression depth for an adult victim? In other words, how deeply do you compress? Is it A, about 1 inch, B, at least 2 inches, C, about 3 inches, or D, no more than 1.5 inches? Do you know the compression depth for an adult victim? And if you chose B, you certainly do. So adult chest compression should be at least 2 inches or 5 centimeters, but no more than 2.4 inches deep. 2 inches or 5 centimeters. All right, question 3. Which action is the first step in the chain of survival? Is it A, early CPR, B, advanced life support, C, rapid defibrillation, or D, activation of the emergency response system? Revealing the answer in 5, 4, 3, 2, and if you chose D, you have it. So the first link in the adult trainer survival is number 1, recognizing cardiac arrest, recognizing when a person is pulseless and not breathing. And then secondly, we'll be activating EMS, the emergency medical services. And so whenever you watch some of the videos, they don't say call 911. They don't say call a code. Instead, they're going to say EMS because they don't know where you work. If you're inside of a hospital, you are 911 until the rapid response team gets there. So you're going to call a code. You begin your chest compressions, and when your other team members come around, they will then start taking over the care. If you're in a home care setting or in a clinic, well, you more than likely will have to call 911 because we have to get that person to a hospital in case they need additional services. So that is the difference. That's why in your video, it doesn't always say call 911. It says, hey, you go get help, come back, activate EMS or call EMS. Question 4. When giving compressions to an infant, which is the correct depth? Is it A, 1/4 inch, B, 1 inch, C, at least 1.5 inches, or D, at least 2 inches? All right, revealing the correct response in 5, 4, 3, 2, and if you chose C, great job, team. For infants, compression should be at least 1.5 inches or 4 centimeters deep, or about 1/3 the depth of the chest. Question 5, how often should you switch roles during to rescue or CPR? Would you switch A, every 2 minutes, B, every 5 minutes, C, after 10 cycles, or D, only when exhausted? All right, revealing the answer in 5, 4, 3, 2. Yes, it is A. So even if you don't feel exhausted, if you are doing things according to the American Heart Association, the American Red Cross guidelines, you're going to be switching every 2 minutes. So if you have help, switch, because switching helps prevent fatigue and it maintains high quality compressions. Question 6, what is the compression to ventilation ratio for one rescuer adult CPR? Would it be A, 15 compressions to 2 breaths, B, 5 compressions to 1 breath, C, 30 compressions to 2 breaths, or D, 20 compressions to 1 breath? So that's a ratio. It's 15 to 2, 5 to 1, 30 to 2, or 20 to 1. All right, put those thinking caps on. Revealing the answer in 3, 2, and yes, it is 30 to 2. It is C. So for adults, a ratio of 30 to 2 is standard when performing CPR alone. So single rescuer, 30 compressions followed by 2 breaths. And if you need this in writing, you all, we have free study guides. Go to nurseunits.com and download your free study guide today. Question 7, when should the rescuer initially ensure the scene is safe? Is it A, after assessing the victim, B, after calling 911, C, upon arrival at the scene, or D, after delivering the first breath? When should the rescuer initially ensure that the scene is safe? And if you said C, all right, you are correct, because before we even provide care, we have to make sure that it's safe for us to be there. So scene safety is always the first step before approaching the victim. If the scene is unsafe, you will not approach. You will call 911 from a safe distance. You matter also, so do not try to render aid if there's a possibility that you yourself can get hurt. Question 8, what is the most reliable method to confirm effective rescue breaths? Is it A, watching for chest rise, B, listening for breathing, C, checking the carotid pulse, or D, using a pulse oximeter? All right, revealing the correct response in 5, 2, and 1. The most reliable method for confirming effective rescue breaths is A, watching for visible chest rise. If you don't see the chest rising, you're going to reposition and reattempt, but at no point should it take you longer than 10 seconds to administer 2 breaths. If it takes longer than that, worry about them after you go back to your 30 compressions. Question 9. Which victim requires only rescue breathing and not compressions? Is it A, an adult who is gasping? B, a victim with a pulse but no breathing? C, a victim who collapsed suddenly? Or D, an infant with no signs of life? And let's read that question again. Which victim requires only rescue breathing and not compressions? This one's a little trickier, so we'll reveal the answer in 5 additional seconds. And if you chose B, you have it. So B is the correct response. If they have a pulse, but they are not breathing, you're going to supplement their oxygen by giving rescue breaths. You would not be giving rescue breaths to someone who's gasping. Maybe they need an asthma treatment. Maybe something else is going on with them, but they're gasping. So even though it may be a partial obstruction, they are still breathing at this point. So right now, that would not be the correct response. You would not be providing rescue breaths to someone who is gasping. You would monitor them and notify the physician. Question 10. What is the correct hand placement for adult chest compressions? Is it A, one hand over the abdomen, B, one hand in the center of the chest, C, 2 hands on the upper abdomen, or D, 2 hands on the lower half of the sternum? Reveal the answer in 3, 2, and it is D. So hands should be placed on the lower half of the sternum while avoiding that very bony end, the xiphoid process. And I know a lot of you, especially if you've been taking CPR a long time, you like to try to measure the intercostal spaces. Remember, most adults are too fluffy. You can't feel our ribs. So I like to say, just imagine that the person has a perfect nipple line, even if the breasts are pendulous and hanging. Once that chest is exposed, put your hands in the lower center of their chest and start doing your compressions without trying to measure the 5th intercostal space. All right, question 11. What should be done immediately after the AED delivers a shock? Is it A, wait for the AED to reanalyze, B, check for a pulse, C, resume CPR, or D, deliver rescue breaths? So after the AED delivers a shock, you're going to do C. There is no residual charge. You put your hands back on that chest and you start resuming high quality CPR. So it is C, resume CPR immediately after shock delivery without checking the pulse. Remember, the AED will be analyzing the rhythm every 2 minutes. So it's going to let you know to take your hands off so it can reanalyze. And that kind of takes away the need for a pulse check until the advanced providers come along. Excuse me for clearing my throat. Question 12. For an adult, how often should rescue breaths be given if they have a pulse but no breathing? So they have a pulse, but they're not breathing. We know we're going to give rescue breaths, but how frequently? Is it A, every 5 to 6 seconds, B, every 6 seconds, C, every 10 to 12 seconds, or D, every 15 to 20 seconds? And I know with this one, you're torn between A and B, but according to the current standards, it is B. A is the old standard. So now for an adult victim, we give a breath every 6 seconds. You'll provide 1 rescue breath. So again, according to the current American Heart Association guidelines, provide 1 breath every 6 seconds for an adult with a pulse who is not breathing. Question 13. When should rescuers switch roles in 2-person infant CPR? Is it A, every 3 minutes, B, after each AED shock, C, after every 2 minutes, or D, after 15 compressions? All right, revealing the answer in 3, 2, and you all, regardless of the age, you are switching compressors every 2 minutes, whether it's an adult, child or infant. And remember, I have a video on YouTube that is an actual video refresher of me performing adult, child, and infant CPR. You can refresh yourself in less than 20 minutes. And the video link is down below. All right, so question 14. What is the preferred method or technique for giving compressions to an infant with two rescuers? Is it A, one hand technique, B, two thumb encircling hands, C, the heel of one hand, or D, two finger technique? The preferred technique if there are two rescuers with an infant is going to be B, the two thumb encircling hand technique. The way I like to think of this, because we know that children and infants, if they go into cardiac arrest, more than likely it was their airway. Well, this way we give the respiratory therapist the airway. They can manage the airway. If they need to intubate, they need to trach, we're not blocking them. So you, as the compressor, you take the lower half of the infant, and that allows the respiratory therapist to monitor, to manage the airway. So the two thumb encircling hand technique provides better depth and consistency, and it also allows the respiratory therapist to do what they do and manage their airway without you being so close to them. All right, so that is the position if there are two rescuers for infant CPR. Question 15. What is the recommended compression to ventilation ratio for two rescuer infant CPR? Is it 30-2? 15-2, 5-1, or 20-1? The compression to ventilation ratio for two rescuer infant CPR. All right, revealing the answer in 3, 2, and the correct answer is B. Two rescuer CPR for infants and children uses a ratio of 15 compressions to 2 breaths. Let's think about the reason that a child or an infant goes into cardiac arrest. I just stated it. It's usually because of airway. Maybe they drowned, maybe they asphyxiated, maybe they had an asthma attack, anaphylaxis. But right now, we need to supplement their oxygenation. We have to give them more breaths. And so when you switch to a ratio of 15-2, within the same 2-minute window, remember we switch every 2 minutes, you end up giving double the breaths. So with 30-2, you only give 10 breaths. When you switch to 15-2, you're giving closer to 20 breaths. And that's going to help provide the extra oxygenation that a child or an infant needs. Don't forget, they also breathe faster than adults. So we need to give them oxygen more frequently, or breaths more frequently. Question 16. How soon should CPR be started after recognizing cardiac arrest? So we tap and we shout, hey, are you okay? Are you okay? No response. We're going to activate EMS. We're going to call the code. We're going to pull out our phone, call 911. We're going to feel for the carotid pulse. We're also going to be checking for breathing. How long should all of that take? Is it A, within 30 seconds, B, within 1 minute, C, within 10 seconds, or D, after calling 911? So once you realize this person is pulseless, how long do you have before you start your high quality chest compressions? And if you said 10 seconds, ding, 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 you are an awesome caregiver. It is C. So high quality CPR should begin within 10 seconds to improve survival chances. Question 17. When using a bag mask device, how many rescuers are preferred? So think hypothetical. Think that you have a full medical team. How many people do you want using the bag mask device? Is it A, 4, B, 3, C, 2, or D, 1? All right, revealing the answer in 3, 2, and it is C. There are 2 rescuers. So one is going to maintain the seal, and then one's going to squeeze the bag. And then I can't give you any more information, because if I do, I'll be giving away a future test answer. All right, question 18. If a choking victim becomes unresponsive, what is the next step? That's right, because BLS not only covers chest compressions for all ages, so CPR for all ages, it also covers how to handle choking emergencies. So if a choking victim becomes unresponsive, what do you do after that? Would it be A, begin CPR starting with compressions, B, continue the abdominal thrust, C, check the airway, or D, deliver 2 rescue breaths? We're revealing the answer in 3, 2, and whenever a victim becomes unresponsive, you want to start CPR immediately. So the answer is A. And whenever you begin CPR, remember we begin with chest compressions. Whenever you go to give the breaths, you can look for the obstructing object. If you see it, you can remove it, but it's going to be chest compression first. Question 19. What action is part of high performance team dynamics? What action is part of us working together during a high performance team activity, such as a code? Would it be A, ignoring roles, B, closed loop communication, C, acting independently, or D, all rescuers doing compressions? And this may be a new term for you all, so I want you to make sure you write this term down. The only option here that is a part of high performance team dynamics would be B, closed loop communication, verbalizing what you heard. And so I love this image. And so let's say this is one of our doctors who has a strong accent. And this patient who's in cardiac arrest was on contact isolation. So in addition to having an accent that can sometimes be hard to understand, we also have on full PPE, including mask. So I can't read his lips. So I want to make sure that if he gives me an order, I repeat it back to him. I'm closing the communication loop. And so closed loop communication ensures orders are understood and confirmed. Question 20. What should you do if the AED says no shock advised? Is it A, resume chest compressions, B, remove the AED, C, check the pulse for 30 seconds, or D, deliver a rescue breath? And I want you to think about this. Why would the AED say no shock advised? Has the person achieved ROSC? Do they now have a pulse? Or is the patient now in asystole, which is a non-shockable rhythm? So when the AED says no shock advised, don't get tricked. Resume CPR. It is A, great job. All right. And even if the person did have a pulse, right now the pulse could be 10, it could be 20. Because remember, we don't, whenever it already did the pulse check. And so once it did the pulse check or it checked for the rhythm, it said no shock advised. Go ahead and start CPR. All right, keep starting your CPR, resume it, because if it does not advise a shock and there are no obvious signs of life, such as a person moving, you're seeing chest rise, it could be that a person went into a more lethal arrhythmia, that they're now in asystole, which is non-shockable. Question 21. What is the proper compression technique for a child using What is the proper compression technique for a child if there's only one rescuer? I want to make sure that I reread that one. What is the proper compression technique for a child if there's only one rescuer? Is it A, 2 fingers, B, 2 thumbs, C, 1 hand or 2 hands depending on the child's size, or D, the heel of 1 hand only? And the child is from 1 to puberty, age 1 to puberty. So if the young girl, if she has breast bud development, we consider her an adult. So this is somebody who has not reached puberty. Would you use 2 hands, 2 fingers, 2 thumbs, 1 hand, 2 hands, or just the heel of your hand? It's going to be C. For a child, use 1 or 2 hands based on the child's size to ensure proper depth. Something that I like to add, especially if you don't have the upper body strength, is if you only use 1 hand and that child doesn't make it, for the rest of your life, you're going to be stuck with thinking, could I have done more? So unless it is a really small child, I recommend that you use 2 hands. You're not going to compress too deeply. Most laypersons and most novice professionals, they don't compress deeply enough, which is why whenever you take your CPR classes, your mannequins, your devices have to have feedback devices that click light so that you understand how deeply you have to compress. And for a child, you're still compressing 2 inches or 1/3 the depth of the chest. 22. What is the correct sequence of steps in adult BLS? Is it A, airway breathing compressions, B, breathing compressions AED, C, compressions airway and breathing, or D, AED compressions and breathing. And that's a lot, so I'm going to give you about 10 seconds to read through that. And if you understand the current guidelines, which have been in effect now for about 10 years, you understand that the correct sequence of steps in adult BLS is CAB. It is CAB, compression, airway, and breathing. So if your patient's in cardiac arrest, your focus is on high quality chest compressions. If you're a single rescuer and they vomit, what do? Do you turn them to the side, or do you keep doing your chest compressions? Remember, your priority is CAB, C-A-B. If you take your hands off the chest or turn them to the side, what happens to the blood flow to the brain? It stops. They're going to be brain dead. So you keep doing your compressions. You can turn their head, try to sweep out their mouth within the 10 seconds. But if they get vomitus in their lungs, we call that pneumonia. We can treat that with time, intubation, antibiotics. You take your hands off the chest and you stop blood flow to the brain, that's brain death. We can't reverse that. So until your team arrives, it is C, compressions, compressions, compressions. Once your team arrives, they can then help and focus on the airway and the breathing. Your team will be bringing a crash cart. They'll also be bringing the first aid equipment. And so you just keep compressing. If you don't know what else to do, keep compressing until someone tells you to do otherwise. I love this image. This is one of our CPR classes. When I say CPR, I mean an American Heart Association basic life support. So these are our professional rescuers. And so we are worth the drive or the flight. You can look at our class schedules at fltraining.com. We need at least one day. Like we literally will have you attend your instructor course in the morning and then have your monitoring session in the evening. You're going to have a long day, but when you leave, you are going to feel knowledgeable, empowered, and more than that, you're going to be certified. And so if you're interested, go to our website. Question 23. What is the purpose of defibrillation? A, it starts a stopped heart. B, it delivers medication. C, it increases oxygen to the brain. Or D, it stops an abnormal rhythm. What is the purpose of defibrillation? Revealing the answer in 3, 2, and I know this one was tricky, and I know you wanted to choose A. But what if the person was in a systole and that was the cause of their stopped heart? So the purpose of defibrillation isn't to start a stopped heart because it can't fix everything. But it would be D. The goal would be to hopefully, let's give you the correct answer, to stop the abnormal rhythm. So defibrillation stops fibrillation, such as VFib, ventricular fibrillation, to allow the heart to reset and beat effectively. Now we're going to question 24. When should the AED pads be removed? Is it A, after CPR, B, once a pulse is detected, C, when instructed by EMS, or D, never during a resuscitation effort? All right. I think everyone has their answers now, so revealing the responses in 3, 2, and 1. You all will never take off your AED pad. So the answer is D, during a resuscitation effort. And so even if the person regains consciousness, if they achieve ROSC, we just don't turn off the AED and take off the pads, because when you hear us say we coded a person 3 times, that means that we got a pulse and we lost it again. We got a pulse and then we lost it again because we never went to the H's and T's that advanced that ACLS part. So we don't know what's wrong with them that keeps causing them to go into ventricular fibrillation. And so don't turn your AED off. The advanced professionals, once we have that patient stabilized, will let you know when to turn off the AED. All right, you all. Question 25. What is the recommended compression to breath ratio for 2 rescuer adult CPR? So we covered 1 rescuer adult, we covered 2 rescuer infant, and so now we're on 2 rescuer adult CPR. It's you and your CNA in the room. What is the ratio? Is it A, 15-2, B, 20-1, C, 30-2, or D, 5-1? We're revealing the answer in 3, 2, and you all, for adults, regardless of the number of rescuers, up until the point where they're intubated, it is going to be 30-2. So the answer is C. If there are 8 people at the bedside, if that person's not intubated and they're an adult, it is still 30 compressions followed by 2 breaths. And so our little table over here on the side kind of gives a breakdown. So for adults, with 2 rescuers, it's going to be 30 to 2. However, for children and infants with 2 rescuers, because we have enough people to give more breaths, it is going to be 15 to 2. And remember the logic behind it, because we're giving closer to 20 breaths per minute for our children and infants versus for adults, they're only going to get about 10 breaths per minute. So the compression ventilation ratio changes when performing CPR if you have 2 rescuers for children and adults only. For children and infants only. For adults, it will remain 30 to 2. Question 26, and we're going all the way to question 35. What is the main goal of effective team dynamics during a resuscitation attempt? Is it A, allowing multiple leaders to contribute? B, enhancing efficiency and minimizing interruptions? C, ensuring tasks are performed independently? Or D, assigning one person to monitor oxygen saturation? What is the goal of working as a team during a code? Ding, 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 ding. We need to minimize interruptions. We got to keep our hands on that chest. The answer is B. So 80% of the time, you want to be doing chest compressions. We call that chest compression fraction. So something I like to say, which may be inappropriate to some of you all, but I like to say we don't stare at dead people. We're compressing, or we're feeling for a pulse, or we're using the AED, but your hands just coming off the chest. No. Good team dynamics ensure coordinated care, minimizing interruptions, keep those interruptions no more than 10 seconds, and that is how we improve our resuscitation outcomes. Question 27. Which of the following best distinguishes cardiac arrest from a heart attack? Is it A, a heart attack always results in loss of consciousness? B, cardiac arrest involves a sudden loss of heart function and pulse? C, chest pain is never present in cardiac arrest? Or D, a heart attack always requires defibrillation? And because this one is so lengthy, I'll give you about 10 seconds to read everything again. Revealing the correct response in 3, 2, and you all, it is B. So I like to think of the heart as a house. A house has plumbing and it has electricity. When you think of a heart attack, think of plumbing. The plumbing has gotten backed up. And so this person needs angioplasty. He needs us to go in and clean out that artery. So they're still talking to you, but they have chest pain, difficulty breathing, they're nauseated, they could be lightheaded. If they're a woman, they may not have any of those symptoms. They may have back pain. And so women usually have atypical symptoms if they're having a heart attack. Regardless, let the doctor know, get an EKG. Heart attack, they're still talking to you. Meanwhile, cardiac arrest, that's the electrical part of the house. When the electricity goes out, that patient collapses. They're on the ground, unresponsive, no pulse, no breathing. So cardiac arrest is more severe. Cardiac arrest is unconsciousness, unresponsiveness, and absent or abnormal breathing. And so that is going to be the difference between the two. Cardiac arrest requires CPR versus a heart attack. It may require hospitalization, some anticoagulation, or some blood thinners, and also a trip to the cath lab. Or if it's really severe, they may need open heart surgery, but they're still alive. They can talk and they can live to tell their story. If we don't perform CPR properly and someone's in cardiac arrest, they're going to have worse outcomes. Question 28. Why is allowing full chest recoil important during compressions? And so allowing full chest recoil, does it A, increase oxygenation, B, help to prevent rib fractures, C, allow the heart time to refill with blood, or D, does it avoid rescuer fatigue? Why allow the chest to recoil to return to its normal position? Revealing the answer in 3, 2, and it is C. If you always have pressure on the chest, if you never allow it to recoil, remember every time you compress, you're squeezing the blood out of the heart into the circulation. So we're allowing it to circulate to the heart, the lungs, And then when you allow it to recoil, when you allow the chest to expand again, you're allowing the heart to fill back up with blood. So if you're compressing really, really fast, if you're going above 120 compressions per minute, you're doing a lot of work, but inside of their body, their heart doesn't have as much blood flow. So you're supposed to let that chest rise all the way and then compress down again so it's filled with blood, so we will have better perfusion. Question 29. When administering intranasal Narcan or naloxone during suspected opioid overdose, which is true? A, one spray is administered in one nostril. B, it should be administered directly into the mouth. C, it should be only given if the patient is conscious. Or D, it replaces the need for rescue breathing. And yes, as a BLS provider, you can administer intranasal Narcan. We are Narcan providers. We have the Narcan trainers, but you have to come to our office in order to receive your Narcan. So if you're in the Jacksonville, Florida area and you would like Narcan for free, just let us know. We'll have a few boxes available for you. We can do your training in about 5 minutes and we can provide you with Narcan so you can help save others. And so everybody, the answer to question 29 is A. So intranasal, inside the nose, intranasal Narcan is of course administered via the nose, and it's usually one spray. So each of those doses or each of those nasal containers, it just has one dose of medication. And most of your packaging comes with 2 different dosages. And so remember, you're going to do our tap and our shout. This person's still breathing. If they're not breathing, you cannot use intranasal Narcan. If they're not breathing, keep doing your CPR. And when EMS arrives, they can start an IV and they can give intravenous Narcan if they suspect an opioid overdose. So for you as a BLS provider, they still have to be breathing in order for you to administer intranasal Narcan. And then you want to stimulate them, rub on their chest, do that sternal rub. You can turn them to the side. There's a possibility they're going to vomit. Remember, you can turn this person to the side because they're still breathing, their heart's still beating. The opioids, it suppresses their respiration. And so when you give the Narcan, it's going to bind those opioids up. Talk to your provider, talk to your instructor about it, talk to your teacher about it. One thing they don't really tell you that you may not be prepared for is when they do wake up after you have given them Narcan, they don't wake up nice and happy. You just bound up their drugs. So you want to be very careful. And if at any point you have to use Narcan, you need to be calling 911. They need to be en route because, again, if this person goes into cardiac arrest, they may need intravenous Narcan, not intranasal. Question 30. An AED becomes available while you are performing CPR on a pregnant woman. What should you do? A, delay defibrillation due to pregnancy. B, continue CPR, but do not use the AED. C, use the AED as you would on any adult. Or D, turn the woman on her left side before using the AED. And yes, the American Heart Association, they do have guidelines on how to perform AED use on the pregnant mother, and the correct response is going to be C. You're going to use that AED on mom. And I know some of you are thinking like, oh my God, I'm going to shock the baby. But right now, mom's heart is just fibrillating. It's not contracting. So there's no blood flow to the baby. Mom is dead. The baby is dying. Mom's in cardiac arrest. The baby's dying. We want you to use the AED to hopefully restore mom's heart rhythm, to get her out of ventricular fibrillation, to get her pulse, her heart beating again, so we can help save the life of the baby. And so research has indicated that AED use is safe and appropriate in pregnancy because saving the mom's life is top priority if we want to save the baby's life. Question 31. Which of the following is a contraindication to using an AED? Is it A, the patient is on a metal surface? B, the patient has a DNR or a do not resuscitate order? C, the patient is pregnant? Or D, the patient has an implanted pacemaker? Which is a contraindication? I know this one's hard, right? The answer is B. If someone has a do not resuscitate order, we're not performing those life-saving interventions like defibrillation. And so it's actually a misconception to think that you cannot use an AED on a metal surface because according to the American Heart Association guidelines, metal surfaces pose no shock hazard to either the victim or the rescuer. And then in addition, in cases that involve water, let's say drowning incidents, you can still use the AED if a person is drowned. You just have to remove them from the freestanding water and only dry off their chest before using the AED. And I think the other one was an implanted pacemaker. And so usually your doctors are so smart, they put the pacemakers on the left side. And so your AED pad goes on the right. And so you can still use your AED if a person has an implanted device. You just cannot put your pads directly on top of the implanted device. And so that is why the latter was not a true contraindication either. Question 32, going all the way to 35. If you have liked this video, if you learned something, put what you learned in the chat and give us a thumbs up. We are so close to having 1 million subscribers on YouTube, and we couldn't do it without you. So thank you all for letting me be your online nurse educator. Question 32, during a resuscitation attempt, the team leader assigns roles and uses closed loop communication. What is an example of closed loop communication? A, everyone start CPR. B, can someone get the airway? D, give 1 milligram epinephrine IV now, and then followed by a repeat, the person saying epinephrine given 1 milligram IV. Or is it D, just do whatever you can? All right, so we know it's not D. And I know you remember my scenario from earlier. So closed loop communication means that we close the communication gap. And so it's going to be C. If you tell me to give 1 milligram of IV epinephrine, I'm going to let you know once it's been given. I should not take any more tasks until I do the first task. So that is how we close the loop. We confirm and we repeat back instructions, and that helps us to prevent errors. Question 33. When performing compressions as part of high-performance CPR, what is the recommended rate for infants? Is it A, 60 to 80 compressions per minute, B, 100 up to 120 compressions per minute, C, 120 up to 140 compressions per minute, or D, as fast as possible? Revealing the correct response in 3, 2, and you all, they simplified CPR. Regardless of the age of your victim, it's going to be B. We're always compressing 100 up to 120 compressions per minute. And so this rate maximizes blood flow without causing incomplete chest recoil or rescuer fatigue. So whether it's an adult, child, or an infant, your goal compression rate is 100 up to 120 compressions per minute. Question 34. Which action is inappropriate when using an AED? In other words, which action would you not do? Would it be A, removing wet clothing before attaching pads? B, placing pads over a medication patch? C, placing one pad on the upper chest and one on the side? Or D, using adult pads on a child if pediatric pads are not available? So which one of these would not be appropriate? All right, and if you chose B, you have it. You all were not placing an AED pad on top of a medication patch because doing so could cause arcing, which is like a fire, or it can reduce the effectiveness of the pad. Something else is, let's say that's a nitroglycerin patch, and we apply heat to a nitroglycerin patch. We're about to give this patient a mega dose of nitroglycerin or fentanyl, plus we're going to singe that pad. We're going to burn that pad to their skin. And so what I don't like about this particular image is, yes, with their bare hands, they're showing you the medication patch, but you as a rescuer should never remove a medication patch with your bare hands. If you don't have gloves, get something plastic. I don't care what it is. It could be a sandwich bag. It could be a bag out of the trash can because this is not sterile. You're trying to save their life. If you decide to move a medication patch with your bare hands, remember that medication can go into your skin. It could be fentanyl. This could have been a cancer patient. And now you are going to have the untoward effects. And so you would not remove it with your bare hand. And you also cannot remove it with clothing because clothing is permeable, meaning that the medication, especially if they're sweaty, it can seep through and it can still get onto your skin. Question 35. I can't believe we're almost done. What is the first step you should take when you see someone collapse? Is it A, start compressions immediately? B, call the patient's family? C, check for responsiveness and breathing? Or D, attach the AED pads? All right, so we're in the mall and we see someone collapse. What's the first thing we do? We need to do C. We have to check for a pulse and for breathing. Did they collapse because they fainted? Did they collapse because their blood sugar was low? If either of those two were the case, they'd still have a pulse and they'd still be breathing. So yes, they'd need emergency attention, but they wouldn't need CPR. And so that's why I love this image. You have a patient who's on their side, and maybe you called their name and they didn't respond. And because they're on their side, you can't see their chest rise and fall. Well, that's when you go in and you assess your patient. You tap and you shout, you try to stimulate them. And then if that doesn't work and there are no signs of life, you're going to be checking that pulse. Again, maybe they're unresponsive because of medications. Maybe they're super sleepy, or maybe their glucose level's low. But we don't know if you don't first check for responsiveness and then check for a pulse and breathing. And so you all, as I promised you, in addition to having our BLS test prep videos, we also have ACLS, we have PALS. You can find that our YouTube channel, which is youtube.com/Florida training. And it has been so wonderful being with you all today. We have our free study guides. Don't forget at nurseunits.com. And then all of the American Heart Association CPR instructor, BLS, ACLS, PALS, Heart Saver, and we also have CPR and business development courses, because once you become a CPR instructor, it doesn't teach you about the business, and that's what I'm here to do. So everybody, it's been a pleasure. I will see you in the next video, and then good luck with your test, and thank you for being a lifesaver. Bye everybody.